time to actually seek evaluation. What the testing looks like for both partners, and then what we do, or what I would do as a physician with those results, and how I use those results to determine what the best treatment plan is for you guys. We'll give brief overviews of the different types of treatment, why one treatment might be more appropriate versus the other, and what you can expect during the different treatments. We'll talk about what the success rates of those different treatment options are, what risks you might expect, and then, just very quickly, we'll go over what might be the emotional and practical resources that you can employ to really make this journey as smooth as possible for yourself. Next slide, please, Julia. Okay, so what is infertility? How do we define infertility? When should you be seeking evaluation? Well, first of all, how common is fertility? Infertility might actually be more common than you think it is. The WHO estimates that worldwide, about 1 in 6 couples actually experience infertility. And here in the United States, in 2022 alone, there are about 3% of all new babies that were born via the use of ART. So when should you start to seek evaluation? The timing of seeking evaluation is really based on the definition of infertility. So we define infertility based off of the age of the female partner. And I want to stress, this is not because the male partner doesn't have a part to play, but it will become more evident as I go on as to why we use the age of the female partner. So if you have been trying, if you're under the age of 35 and you haven't gotten pregnant within 12 months of trying to conceive relatively frequently, and then we will relatively consistently, you will be diagnosed as having infertility. And at that time, you should be seeking treatment as to what might be the cause of that infertility. If you're older than 35, that time frame shortens to 6 months. And if you're 40, we really say you should be seeking help as soon as possible. Here in the United States, again, in 2022, there were over 400,000 ART cycles performed. ART stands for Assistive Reproductive Technology. And then over or very close to 200,000 banking cycles. Banking cycles refers to fertility preservation by either freezing your eggs or freezing embryos. And then out of those, there were close to 100,000 live births from those ART cycles that were performed here in that time. So really the key takeaway from this slide is that infertility is very common, and thus the use of ART is more common than you might think. But the use of ART is not limited to just the use of fertility. It's also used to preserve fertility in a way of preserving your options further down the line. And really the success of ART is very age dependent. The younger you are, the more likely you are to have success with these treatment options. Next slide, please. So what is the basis of infertility, and why do we do what we do? And all of this is predicated on the fact that in your ovaries, you are born with all the follicles you're ever going to have. What does that mean? It means that you don't make any more. What you are born with is what you have. So in this schematic here, these pink circles represent the follicles, and those tiny black dots within those pink circles are the eggs within those follicles. And like I mentioned, you are born with all the follicles and are not making any more. What happens every cycle is that some of those follicles begin to grow, but then they stop growing and they die. And so we lose those follicles and the eggs that they contain. And this is the main reason why our egg count declines as we age, because every cycle we are losing a cohort of follicles and the eggs that they contain. But very importantly, it's not just the number of those eggs that decrease or the number of follicles that decrease, it's the quality of those eggs within those follicles. And what determines egg quality for the most part is the genetic material in those eggs. So our eggs, our DNA is packaged as chromosomes, and each egg is supposed to have a certain number of chromosomes. But as we get older, because we don't make any more new chromosomes, those chromosomes just start to accumulate a lot of genetic error. And this is the main reason why our fertility declines as we get older. It's not just that we have fewer eggs, it's what is more important is the quality of those eggs. And as we start to accumulate more and more genetically abnormal eggs, we see a decline in our fertility. Next slide, please. And that's what this graph here shows. So on the horizontal axis is the age of a person. What you can see is that as we get older, this blue line goes up. This blue line here represents the proportion of eggs you have in your ovary that are genetically abnormal. That term, aneuploidy, just means having the wrong number of chromosomes. So as we get older, we start to have more and more eggs that have the wrong number of chromosomes. And as a result, the live birth rate, so the chances of having a child, which is this red line here, decreases. On the other hand, what you can see increasing is this green line. And this green line here represents the miscarriage rate. And what you can see is that as we age, the rate of miscarriages become higher. And why is this the case? This is because we have more genetically abnormal eggs in our ovary. And if you remember from that previous slide, typically we are ovulating one egg. And the more abnormal eggs you have, the higher the likelihood that that single egg you're ovulating is genetically abnormal. And if that egg gets fertilized and it results in an embryo, and that embryo results in a pregnancy, the most common outcome for embryos that don't have the right number of chromosomes are miscarriages. And that is the reason why miscarriages increase as we get older. Next slide, please. And so really, what happens when you present to a fertility journey? First of all, preface this by saying all of this, one thing I say to all my patients is that we're going to take this one step at a time. We're going to do some tests, we're going to find some answers, and then determine what the right treatment course based off of those answers that we get. So initially, when you come in, just as you would with any doctor's office, we're doing a history and physical, we're doing a whole bunch of tests, we're getting some answers, we come up with a treatment plan, and then hopefully we end up with a pregnancy, or we may need to pivot and figure out something different. Next slide, please. So when you present to the clinic, one of the very important things is bring any prior testing that you've done. So that includes any imaging, any lab work. I want you to come prepared with a list of your medications and any supplements that you might be taking. And what we're going to be discussing what your cycles are like. We're going to go over what your prior pregnancy history is and perhaps your family history as well. And I love it when my patients come to the clinic or to the office with questions to ask. What are we going to do together? We're going to go over what your goals and your timeline is. We're going to go in detail your medical history. We're going to discuss what any prior treatments you had, what the success or lack of success with some of those treatment options are. And then we're going to go stepwise to come up with a plan and what our next steps would be. So what is the evaluation for a couple who comes in with infertility? Well, for me, it's very important to talk about how things work normally, because this explains why we need to, what we're testing and why we're testing that. So normally, what needs to happen in order for you to successfully conceive? From your ovaries, you need to be ovulating at least one egg, and that egg will come out of your ovary and then move into the fallopian tube. Once it gets into the fallopian tube, it needs to be met by sperm that has been able to travel from the vagina to the cervix to the uterus. And then the egg and the sperm are going to meet in the fallopian tube. Once they get into the tube and once they meet, they form an embryo. That embryo, after a few days, will then move out of the fallopian tube and then implant into the lining of the uterus. So when we're trying to figure out what is causing your infertility, we are checking each of these components. So what are those components? In your ovaries, first of all, I want to make sure that you are ovulating regularly, and also to figure out what we call your ovarian reserve. Basically, how many eggs do you have? Now, it's important to mention at this point that the number of eggs that you have doesn't predict whether or not you're fertile or whether or not you have infertility or not. What do I mean by that? I mean that someone with a higher egg count could be less fertile than someone who has a lower egg count. But what is important about knowing what your egg count is that it gives us a time frame within which we are going to work. And it also gives me an idea of what might be a more appropriate or less appropriate treatment option would be for you. And then we want to check to see if your fallopian tubes are open because this is where fertilization happens, right? This is where the egg and the sperm meet. And so we need to make sure that your tubes are open so that there is somewhere that the egg and the sperm can meet. If the fallopian tube is blocked or partially blocked, sometimes the embryo can form, but then it can't move out of the tube and then move into the uterus. And this is how we end up with ectopic pregnancies. Then the other component of the workup is evaluating the uterine cavity because this is where the embryo is going to implant. So we need to make sure that the cavity is, I guess, a hospitable enough environment or that there isn't anything in the cavity that could make it hard for that embryo to implant. And then finally, we want to check the quality of the sperm. Is the sperm going to be able to make it from the vagina, actually make that journey from the vagina to the cervix to the uterus? And then once it's in the tube, is it going to be able to fertilize the egg itself? And so that's one of the very important components. A lot of people don't realize that checking the sperm is actually a very important part of this. In up to 30 to 50% of couples with infertility, there usually is an issue with the sperm, either on its own or together with issues in the female partner. So it's very important to make sure that we have evaluated the quality of the sperm as well. So we can move on to the next slide. So yeah, this slide here just is given a brief rundown of what I have just talked about. One, we're looking at the ovaries and making sure that you are ovulating regularly. Are your tubes open? Is the uterine cavity a hospitable enough environment? What is the sperm quality like? And then what are the factors that might want to make us choose one form of treatment versus the other, and maybe perhaps work in a certain time in a shorter time frame? And those factors basically are the age of the female partner, your ovarian reserve, and perhaps other medical history issues. And so what are we looking at on the sperm? There are 3 or 4 main components that we're evaluating in the sperm. We want to look at what the volume of the sperm is, the concentration or the count of the sperm, the motility, which refers to how well the sperm cells move, the morphology or the shape of the sperm. And like I said, in about 30 to 50% of cases, there might be an issue with the sperm. And it's very important to identify these issues because it determines what the most appropriate form of treatment options are for you. And so based off of the different treatment options, right? So if the test suggests that you may have an issue at the level of your ovaries, meaning perhaps that you're not ovulating regularly, we describe you as having ovulatory dysfunction or ovulatory infertility. If the issue is at the level of your fallopian tubes, then we describe you as having a tubal factor infertility. If the issue is in your uterus, then we describe you as having a uterine factor infertility. So what may be in the uterus? We're talking about things like polyps or fibroids, or sometimes you could have scar tissue that could make it hard for an embryo to implant. If the issue is at the level of the sperm, then we describe that as a male factor. Now, sometimes we can do all of these tests and everything seems to be normal. So you're ovulating regularly, there doesn't seem to be an issue in your ovaries, your tubes are fine, the uterine cavity is fine, the sperm is fine. A lot of people have the misconception that when everything is fine, it means you don't have infertility. Unfortunately, that is not the case. Even though we can't find an answer, as long as you haven't gotten pregnant within those timeframes that we talked about, you do meet criteria for the diagnosis of infertility. It just means that, unfortunately, the tests that we have cannot really figure out what is causing that infertility, in which case we define you or we describe you as having unexplained infertility. This does not mean that you don't need treatment. It likely still means that you need some sort of treatment, even though we're not quite sure what might be causing the infertility. And so what doing all these different tests does is that it allows us to know and to select the most appropriate treatment option for you. So my job as an RAI is to figure out what may be causing you infertility, if that's possible. And your job really is just to focus on those things that you can control. So questions my patients will always ask is, what are the things that I can be doing in order to improve my success? Well, there isn't any magic bullet. There isn't any magic medication that can, improve egg quality, improve sperm quality. But the things that you should be doing if you are looking to conceive is one, to make sure that you are taking a prenatal vitamin that has enough folic acid in it. One, that if you have any toxic habits, such as, vaping, smoking, you really want to start working on cutting this down. Alcohol as well, you really want to try and cut down alcohol, ultimately decreasing your alcohol intake. Caffeine is fine. We say 1 cup of coffee, so that's about 200 milligrams of caffeine is fine. When you are pregnant, leading up to pregnancy, coffee is perfectly fine. And then generally making sure that you're sleeping well enough, making sure that you're getting a good amount of exercise. What is a good amount of exercise? We say about 150 minutes per week of exercise. And then once we've come up with your treatment plans, want to make sure that you are optimized to actually get into a treatment plan. So what does that mean? Making sure that all the right medications have been ordered, making sure that other hormones, which are not necessarily, may not necessarily be, the cause of your infertility, but are associated with fertility outcomes, such as your thyroid, are well controlled. And then you want to make sure that you have gotten all the necessary vaccines that you need before and after pregnancy. And then for the male partner, making sure that there are not active exposures to things that could affect the sperm quality, such as like heat exposure or taking steroids. And then making sure that, both of us, both me as your physician and you as a patient, both understand what the treatment options are and what the plan is, how it's going to proceed. So once we've done the testing and we've decided, okay, it's time to start treatment, what are these treatment options? I would describe it as a lower intervention form of treatment, is something called timed intercourse. Now, timed intercourse is basically just us telling you when the proper time to have sex is. But usually we just don't tell you when to have sex. We help your body get ready so that it is ready to be in that position where you're in that right window to maximize your fertility. And that process is called ovulation induction. What that just essentially means is that we give you medication that ensures that you are ovulating, or you develop a follicle that you could ovulate from, perhaps one, perhaps two follicles. And when you are ready to ovulate from that follicle, we may give you something called a trigger shot, which tells that follicle that it's time to release that egg. And then sometime within that time frame of you taking that trigger shot, we will give you instructions for you and your partner to have sex. And then about 2 weeks after that window, we would bring you back and do a pregnancy test. One thing that you should know about the medications that we give you to develop a follicle. So we have one or two of those medications. They're called letrozole or Clomid. They're oral medications that you take for about 5 days. We would bring you back about a week later to see if that medication has worked. And the way we know the medication has worked is that we do an ultrasound and we see on the ultrasound that you have maybe one or maybe two follicles. The one thing you should know about these medications is that they may allow you to develop perhaps more than one follicle. And if you do develop more than one follicle, there's a potential that you could ovulate from more than one of those follicles. And that's why with these medications, there is a risk, albeit small, of having what we call multiple gestations, so basically ending up with either twins or sometimes, although very rare, even triplets. So if we started out with timed intercourse and that didn't work, or we may just move straight to another form of treatment called IUI, or intrauterine insemination. What this essentially means is that we're taking sperm, washing that sperm, and then putting the sperm inside the uterus. The process leading up to the IUI is pretty much the same as the timed intercourse, meaning that we give you one of those two medications, either Clomid or letrozole. You take that medication for 5 days. We bring you back a week later to see if that medication has worked. And if you've developed one or maybe two follicles, we will give you that medication called the trigger shot that would tell those follicles to release their eggs. And then about 24 to 36 hours after you take that trigger shot is when we would do the IUI. And then again, just as with the timed intercourse cycle, we bring you back about 2 weeks later to see if you are pregnant. So this is just a quick depiction of the IUI. Here we take the sperm, we wash the sperm, and then using a very thin catheter, we put in a speculum into your vagina so that we can see your cervix. And then using a thin catheter, that catheter goes through your cervix and then introduces the sperm into your uterus. And then, the question then really just become like, well, one of the things you might be wondering is, what are the success rates for IUI? And if an IUI doesn't work, like how many IUI cycles do I spend time doing before I'm ready to move on? Well, IUI is it is actually not a very efficient way of trying to get pregnant. We give the success rates of IUI as somewhere between 12 to 20% in the best case scenarios. And what do I mean by best case scenario? I mean like a patient in her 20s or perhaps in her early 30s. So the question then becomes, how many IUI cycles do you spend time doing before you move on to another IUI cycle? Now, and move on to another form of treatment. Now, there isn't any hard and fast answer to that question. It really just depends on the entire clinical picture. So what do I mean by that? I mean your age, what is your ovarian reserve or your egg count, and how many children do you want? My general rule of thumb is that if you are in your late 30s or older, or if your egg count might be on the lower end, or you think you might want multiple children, then it really does not make sense to spend a lot of time doing IUI, because as we've discussed, the success rates for IUI are not very high. IUI is not a very efficient way of trying to build a family. And so if you meet any of those criteria that I just mentioned, I usually will say you should go into an IUI having an endpoint, meaning if after however many cycles of IUI and you haven't gotten pregnant, you should be ready to pivot to something else, because each cycle of an IUI is a month. And that is a month where your egg count and your egg quality could be decreasing further. And the older we are, those month to month decreases or changes in egg count and egg quality could really make a difference. And so generally for all my patients, I just say have an endpoint. And if you are older, meaning in your late 30s or in your 40s, your threshold to move on to something else should really be shorter. And so if you perhaps let's talk about what the next form of treatment is, which you guys may all be familiar with, which is essentially IVF. Now, what are the reasons that we do IVF? If, like I had just mentioned, you have done however many cycles of IUI and it hasn't worked, or IUI or timed intercourse and it hasn't worked, or if number two, your fallopian tubes are blocked. Remember that fertilization happens in the fallopian tubes. IVF actually stands for in vitro fertilization, and that term in vitro means outside of the body. So if your fallopian tubes are blocked, IVF can offer a way of still ensuring that fertilization can happen, because we are fertilizing your eggs outside of the body. The other reason we do IVF is if there are issues with the quality of the sperm, where we think that the sperm is not going to be able to fertilize the egg on its own. Because in the IVF process, we can actually help the sperm fertilize the egg. And then the fourth reason we do IUI is because a couple decides they just want to start out with IVF. They don't want to spend time doing IUI or timed intercourse, either because maybe they're older or they just, feel like this might be a more efficient way of building the family that they want. So what does an IVF cycle entail? If you remember from at the beginning of this presentation, I had mentioned that you were born with all the follicles you're ever going to get. And then every month, some of those follicles would begin to grow, but then they stop growing and they die. With IVF, we are trying to get those follicles that would have died off to instead keep growing so that we can then use the eggs that they contain. So a common misconception with IVF is that by removing eggs from your body, we are decreasing your egg count. We aren't. We are just trying to get those eggs that your body would have lost that month anyway. And so how do we do that? We give you medication. These are injections called gonadotropins, a typical IVF cycle. You are injecting yourself daily for about 2 weeks with these medications called gonadotropins. And you're injecting yourself, and the goal of these medications is so that instead of just one follicle growing in that cycle, you have a whole bunch of follicles that are growing. So you're taking these medications typically daily for about anywhere between 10 to 14 days. And in that 10 to 14-day period, you're coming into the clinic so that we can monitor your response to that medication. Basically, we want to see, are you responding adequately? Do we need to adjust your dose of the medication? And what we should be seeing on the ultrasound is that you have a cohort of follicles that are getting bigger and bigger and bigger. At the end of that 2-week period, once those follicles look ready, you will then have a procedure called the egg retrieval. Next slide, please. So the egg retrieval, it's a minor surgical procedure. So it means that we give you anesthesia and you go to sleep, but it's not like having major surgery. So we don't intubate you, you are controlling your own breathing and you're not paralyzed. And once you are asleep, the way we get those eggs is that we use an ultrasound probe. That probe has a needle attached to it. The probe and the needle will go into your vagina, but then the needle comes out of your vagina and moves into your pelvis and then into the ovaries. The goal of that, the job of that needle is to go into each of these follicles that we can access. It's going to drain what's in those follicles, which is just fluid. It's going to drain that fluid. We then hand that fluid over to the embryologist. The job of the embryologist is then to look under the microscope and find the eggs. Next slide, please. Once we identify the eggs, the next step is to fertilize those eggs. And so there are two ways we can fertilize the eggs. We can just put the egg and the sperm together in a dish and we wait and see if the sperm fertilizes the egg. But remember, one of the reasons why we do IVF is when there are issues with the sperm and we know or we think that the sperm is not going to be able to fertilize the egg on its own. So in those cases, we help the sperm fertilize the egg by doing a procedure called ICSI, intracytoplasmic sperm injection, where we take a single sperm cell and then we inject it into the egg. Next slide. Then once we fertilize the egg, the next step is to see if an embryo actually forms. So day 0 on the schematic is the day of the egg retrieval, and that is the day that we put the egg and the sperm together. Then we check the next day to see if an embryo actually formed. But that embryo is not ready to be transferred or to be used just yet because it's not at the stage where we think it's likely going to result in a pregnancy. We typically will grow those embryos in the IVF lab until they have gotten from that stage on day 1 until they become embryos that we describe as being blastocysts. And it can take up to 5, sometimes 6, sometimes 7 days to get to that blastocyst stage. Once that embryo has become a blastocyst, we have the option of taking one of those embryos and then transferring it into your uterus. But before we transfer the embryo into your uterus, we also have the option of finding out if that embryo is genetically normal. If you remember what I had mentioned at the start of this discussion, that what determines if an embryo is genetically normal is the quality of the sperm, but also the quality of the egg. But as of this time, we really don't have any technology that can allow us to determine whether or not a single egg cell is genetically normal or if a sperm cell is genetically normal. We just put them together and see if they form an embryo. But what we can test, although we can't test the genetic quality of the egg or the sperm, we can test the genetic quality of those embryos that form from the egg and the sperm. And we do that by biopsying those embryos once they become blastocysts. So once that embryo has become a blastocyst, instead of transferring it into your uterus, what we can do is that we take a few cells of each of those blastocysts, then we send those cells, that biopsy sample, off to a genetic lab. That genetic lab will then run the test and let us know, out of each of the embryos that you made that became blastocyst, which one has the right number of chromosomes and which one doesn't. The older you are, the more likely it is that some of the embryos, if not all of the embryos that you have, may not be genetically normal. Because remember, in your ovaries, you have a combination of eggs that are genetically normal and not genetically normal. And the older we are, the more genetically abnormal eggs that you have. So biopsying those embryos and sending that embryo off for testing allows us to know which embryo has the right number of chromosomes. It takes about 2, sometimes 3 weeks to get the result of that genetic testing. So while we wait for that genetic testing results to come back, we actually just freeze your embryos and then we wait to see what those results come back as. Next slide, please. And then once we've identified the normal embryos, if you do decide to genetically test your embryos, once we found out which one of those embryos is normal, we can select one of those embryos, load that embryo into a catheter, and then under ultrasound guidance, transfer that embryo into your uterus. Then typically we would bring you back about 10 days later to see if that embryo resulted in a pregnancy. Now, remember that if you did make multiple embryos, you have these other embryos that are frozen. So if you did get pregnant from that first transfer, and perhaps you were then ready in another year or maybe 2 years, you were ready for another child, you don't have to go through this entire process again. All you would have to undergo is that embryo transfer, the embryo transfer stage of the process. Now, if we did transfer an embryo that had been tested to be genetically normal into your uterus, the chances of, resulting in a child having a live birth from such an embryo are about 60 to 70%. So even if we think that that embryo is normal, it's not a 100% guarantee that this is going to result in a live birth. But 60 to 70%, it's still a relatively high live birth rate. Next slide, please. So this is just a quick rundown of what I've just talked about. It's about, between 8 to 2 weeks of injections and you coming into the clinic for blood work and from ultrasound. You have the retrieval procedure. It's a relatively quick procedure, depending on how many follicles you have. It takes about 10 to 20 minutes. And then once we obtain those eggs, we fertilize those eggs, either by just putting the egg and the sperm together or helping the sperm in that procedure called ICSI. Then we grow those embryos in the lab until they become blastocysts. And then we have the option of transferring one of your embryos and freezing the rest, or genetically testing your embryos and freezing those embryos while we wait for the genetic results of that testing. And we call that pre-implantation genetic testing, where we biopsy that embryo and test it before we transfer it into your uterus. So I didn't really go into detail about what the embryo transfer part of that process looks like. But if we did freeze your embryos, right, it means that we would have to transfer those embryos in another cycle. And so it means that we have to get your body ready to receive that embryo. And so the two goals of an embryo transfer cycle are basically to make sure that your uterine lining is receptive, is thick enough to get that embryo, and then also to allow that embryo to implant, and then also to have a source of progesterone for that embryo to support that pregnancy. And so there are two ways that we do that. We do something called a medicated cycle, where we give you the estrogen that thickens your uterine lining, and then we also give you the progesterone. Or we have something called a natural or modified natural, where your body is producing the estrogen that it needs to thicken the lining, and it also produces the progesterone that it needs to support the pregnancy. Although your body is producing progesterone, we still do give you progesterone, but in a lower amount than we would if we were doing a medicated cycle. And like I said, there isn't one cycle that is better than the other. The pregnancy rates and the live birth rates are fairly equal between the two, but some people may choose one versus the other in terms of So, for example, the medicated cycle, you don't have to come into the clinic as often to be monitored versus a natural. And with the medicated cycle, the progesterone that we give you is in the form of injections. And some people want to avoid having to give themselves injections. And that's another reason why they may choose a natural or a modified natural cycle. All right. Next slide. So this slide here just gives a quick rundown of the risks of fertility treatment in general. So I had mentioned with IUI, those medications that we give you, so Clomid or letrozole, they are allowing your body to develop, to grow, maybe one, but sometimes more than one follicle. And if you do ovulate from more than one of those follicles and those eggs that get released from those follicles are both fertilized, you may end up with multiple pregnancies. Multiple pregnancies are generally considered to be high risk, more high risk than singleton pregnancies. And so this is something that you need to be aware of before you go into that process. Now, one risk of the IVF process is something called ovarian hyperstimulation syndrome. This is where, those medications that we're giving you, what they're essentially doing is stimulating your ovaries to grow some follicles. However, there is a risk that your ovary could become a little overstimulated. We call that hyperstimulation. What happens in hyperstimulation is something that we see more often after the retrieval. What happens here is that your ovaries start to produce quite a bit of fluid, and that fluid can make you feel bloated and very uncomfortable. In the severe cases of hyperstimulation, we may actually need to do an additional procedure to remove some of that fluid from your pelvis and your abdomen to make you feel a little more comfortable. That we call severe hyperstimulation. And those severe cases is not something that really happens very often these days. For some patients, some degree of hyperstimulation sometimes is unavoidable, especially if you're just someone who has a high number of follicles. So it just means that your ovaries may be producing more fluid than the average person. What else are the other risks? The risk, that process of getting your eggs, the egg retrieval, it's a minor surgical procedure. And so with any surgical procedure where you're going into someone's body with a sharp instrument, there's always a risk of injury with that sharp instrument. So what are those risks? So there's a risk of injury to the things around that area we're working with. So like your bladder, your bowel, the ovaries itself, your vagina, your cervix. There's also a risk of infection. These risks are fairly rare. We usually say less than 1 in 1,000. It's not a non-zero risk, but it's a pretty small risk. And then there is always a risk of an ectopic pregnancy. With every pregnancy, there is a risk of an ectopic pregnancy. And then this whole process from start to finish can be fairly emotionally draining, and the uncertainty that comes with this process definitely does not help. So in order to mitigate these risks, what are the things that we do? Well, you've heard me mention that we have you come into the clinic in most of these treatment options fairly often to be monitored. This is a way of ensuring that you are responding appropriately to those medications and ensuring that the dose of your medication is adjusted to what it is that you actually need. Some of the ways that we can mitigate the risk of you developing hyperstimulation is to ensure that we are using the right types of medications. So that trigger shot that we use, there are different types that we can use that help to reduce the risk of hyperstimulation. With IVF, although there's a risk of multiple pregnancies with IUI, these days with IVF, especially because we do genetic testing, we're more frequently doing genetic testing of those embryos, we usually would only transfer a single embryo. And then, if there are concerns for any of these things happening, sometimes we will cancel the cycle just to make sure that we're doing things safely. And then in our network, we have every day we're constantly giving you instructions and making sure that you know where to turn to if any of these things happen and you may need urgent attention. So two things can be true at the same time. Infertility and the treatment can be very emotionally exhausting. And while, like I had mentioned, there isn't any silver bullet, there isn't any magic treatment, it's very important that before you go into this, you identify or you have strategies that may help to reduce the stress involved in this process. Because an improved quality of life, even though it doesn't directly fix infertility, it's not what's going to make an infertile couple fertile. It definitely could just make the process a little more seamless than it might be otherwise, or a little more seamless than it might be otherwise. So, whichever clinic you're going to, you should inquire about what strategies and what support measures they have for you during this process. One of the most important things, and one across, one of them across university, I know that can be quite stress inducing, especially given that things can change on a day-to-day basis, is ensuring that there's adequate communication between yourself, or there are adequate venues to communicate between yourself and your clinical team, whether that's the doctor itself or the medical assistants or the nursing team that are in charge of you. And then really don't underestimate the importance of having community, having friends, if you know people who are going through that same support, or really there are many online peer support resources that can help just reduce or mitigate the isolation and really normalize the experience of infertility. Like I mentioned, infertility is more common than people think that it is. And there might be someone sitting next to you who is going through the exact same thing as you do. More and more, what I'm glad to see is that it's becoming less so this taboo topic, and more people are being open about their experiences. And then finally, like I had mentioned, and identifying strategies that work for yourself in terms of reducing your stress. So things like sleep, mild exercise during your treatment cycles, and practicing mindfulness, and really just scheduling things where you're not constantly scheduling time where you're not constantly away, which is, I know, is easier said than done, but really scheduling time where you're not too or hyper focused or hyper fixed on the whole fertility experience could definitely help. So where are these points where maybe your stress might become a little, or where your stress can be exacerbated during this process? Well, with every IVF or with every fertility treatment, monitoring is required. And depending on the form of treatment, that monitoring may be more frequent than may need to be more frequent than it might be otherwise. And the way fertility works is that, we monitor you, we get blood work and we get ultrasound, and we have to adjust the dose of your medication. So that means that, unfortunately, most of the time you have to come into the clinic fairly often. So you're talking about, especially if you're doing IVF, you're talking about a 2 week frame where you're coming into the clinic like every other day or so, and towards the end of the cycle might be every other day, quite early, so that we can get blood work and ultrasound results back early, and we can adjust your medication dosages accordingly. So that could definitely be somewhere where your stress is definitely increased. Ensuring that you have the right medications, those medications have been delivered on time, those medications are stored properly. Something else that can also, make the process a little more stressful or cause a little bit of friction is ensuring that that process of the prior authorization, which can delay the process. And then, sometimes there is, for example, if you decided to test your embryos, there is that time waiting for the genetic testing on those embryos. And let's say we did end up with genetically normal embryos, we underwent an embryo transfer cycle, and then we have that 10-day period where we're waiting to find out what the result of the pregnancy test is. These are all points where you should probably expect that there will be probably your baseline stress levels may be higher than normal. And while expecting the while knowing that this process is at this point in this process may be more stressful, doesn't necessarily eradicate the stress, knowing that going into this process, knowing that these might be processes or this might be times where things may be a little more stressful than usual, may potentially help mitigate those the stress that these points can induce. So, questions that you might want to ask your physician when you are before or during this process is really, what are the appointment windows times? What are for the monitoring periods, like what are your monitoring window periods? You want to know what the latest time you can come to the clinic is. Like, for example, at my clinic here at Advanced Fertility Center of Chicago, our monitoring periods usually start at 6:30 and usually end somewhere around 9 or 9:30. This is just to, as I had said, ensure that we have those results back on time so that we can adjust the dosages of your medications as needed. What dates do you need to be, in town where you probably shouldn't be traveling? Those are questions that you should be asking both during the ovarian stimulation portion of the treatment and also in the embryo transfer portion of the treatment. What are those things that can lead to the cancellation of a cycle? For example, if I look like I'm at risk of developing ovarian hyperstimulation syndrome, perhaps we're not going to move ahead with an embryo transfer within that same cycle. What costs can you expect? Most fertility clinics within our network have financial counselors that would reach out to you before your treatment starts so that you're not met with any unexpected costs. They will give you a breakdown of what the different treatment costs are based off of the insurance that you may or may not have. And then how do I reach my team, either during monitoring or during office hours or during after hours? Most clinics in our network have we have this app called the Prelude Connect app, and in that app we have a messaging portal. And so most non-urgent questions can be directed to that messaging portal, and typically you might expect an answer within 24 to 48 hours for non-urgent questions. For urgent questions that come after hours, there's usually an on-call person that you can reach out to with those questions. And then something that you should already, and I always discuss with my patients before we start our any treatment, is if this doesn't work, or how long are we going to spend on this treatment before we pivot into something else, and what is that something else that we might pivot into if this doesn't work. So it's important that beyond just the resources that your clinic provides, to know the trusted places where you can get reliable information. One of the most important is the patient education portion of the American Society of Reproductive Medicine website. These are in very trusted, evidence-based information that has been presented in a way that is patient-friendly. There's also the American College of Obstetrics and Gynecology. There's the CDC website. And something that I hadn't mentioned is that I didn't talk about what might lead you to choose one fertility clinic versus the other. You want to know what generally the success rates of one clinic versus the other are. Although I will caution that it might be hard to compare success rates of one clinic to the other because the patient population might be different. But if you just want to get a general idea of how well a fertility clinic does, one way you can get that is by going onto the SART website, where most IVF clinics in the country report their outcomes. And so you can pull that information on there, and that can help you make informed decisions about which might be the best fertility clinic for you. And then finally, we have support groups and advocacy groups. One of the biggest and one of the ones I really, really I admire and support is the Resolve advocacy group.
Okay, thank you so much, Dr. Toomey. We are now going to move into the question and answer segment of this presentation, final part of it. So again, please do feel free to submit those questions in the chat. Let me go ahead and see what we have submitted so far. And also, please do feel free if you would like to ask a question live to do that as well. Okay. First question that we have. So, understanding that this can differ by age and patient's specific situations as well, we have a question that is asking, at what AMH level would you start recommending the use of donor eggs instead of continuing with a patient's own?
That's a very, very good question. So, the AMH is a predictor of how well you might respond to stimulation, and the lower your AMH is, the less likely you are. Now, I wouldn't necessarily say that there is an AMH cutoff that we wouldn't do it, but we don't just look at the AMH, we look at another hormone called your follicle stimulating hormone. And this is a hormone that the brain produces, the lower your egg count becomes. And so the higher your FSH is, the follicle stimulating hormone, the less likely it is that you're going to respond to medications that we give you to stimulate your ovaries. And so most clinics have rather than an AMH cutoff, they have an FSH cutoff because the FSH, usually it's what is going to tell us whether or not you're going to respond to the medications we give you. And in our clinic, our FSH cutoff is 21.
It's very helpful.
So even patients with low AMHs, if their FSH is not higher than that cutoff, may still have some response to ovarian stimulation. So that's why I just caution that there isn't a hard and fast AMH cutoff. We take it and we take the entire clinical picture together.
Very helpful. We have another question here in the chat, and I also sent this answer to the person who sent it. But could you share a little bit more about SART.org and how patients might be able to look at that site, as you were saying, and kind of compare success rates across clinics? I think you talked about some of the caveats to keep in mention. But could you talk about just how that can be helpful a little bit more for patients when they're starting their journeys and looking for
Absolutely.
clinics?
So one of the most important things you want to be looking at is the success rate. So, you know, it can be apples to oranges when you're comparing two different clinics. So one of the most important things that you want to be looking at is what the success rates for that clinic is in your age group. And you then want to be looking at what the success rates are per the parameters, I guess you want to be looking at are perhaps what the success rates are per retrieval or per embryo transfer, because those are different outcomes as well. But like I said, the most important thing when you're looking at the SART data is to look at what the success rates for that particular clinic in your age group. It doesn't make sense comparing the success rates for one clinic in like an age group in their late 30s or in their 40s to another clinic that where in another age where the patient population is on the younger end. So you really want to be looking at age specific data as one of the most important things that you want to try and glean from the SART website.
Yep, it's very helpful. We do have another question here. If you have a pituitary microadenoma, is IUI or IVF more risky for your health?
That is a good question. So, just for anyone who doesn't know, pituitary adenoma is a small tumor in the pituitary gland of the brain that could be secreting a hormone called the most common hormone that those tumors tend to secrete is something called prolactin. Now, IVF treatment has not, or any of the fertility treatments have not been shown to cause any adverse effects of those, or the concern really with those is perhaps the tumor might get bigger, and fertility treatment is not associated with increase in size. But it is very important before you embark on fertility treatment to ensure that if you do have one of those tumors that's secreting hormone, and one of the most common hormones is a hormone called prolactin, that the prolactin levels are well controlled before you go into the treatment, into whatever treatment option, because high prolactin levels could actually affect the success rates of those different treatment options that we just talked about. But just to sum up, fertility treatment does not make or exacerbate or worsen a pituitary adenoma. if that's basically the question that you were asking.
Yeah, I think that covered it. We do have another question here as well. Do the shots that you have to do or the injections for in vitro fertilization, do they have an impact on how you feel? Is it similar to birth control or other hormonal types of medications?
That's a great question. So those medications, what they're doing is that they're stimulating your ovaries to grow your follicles, and as those follicles grow, your hormones, specifically your estrogen levels, are going up. Now, there isn't a textbook answer to that question. Some people feel exactly the same. Whereas some other people may be more sensitive to those changes in their hormone levels. So there is, it varies from person to person. Some people do experience or do report that they feel, they can definitely feel the effect of this change in hormone levels. Whereas for some people, it's just like any other regular day.
That's helpful. Um, I think we are getting close to the end of time, so perhaps we can maybe take one more question. Um, we have a question here that is, if all of our tests are normal, but we have
Mhm.
still been diagnosed with unexplained infertility,
Mhm.
could you explain why IVF is most often the treatment option that is recommended in a situation like that?
So IVF is, if you've been diagnosed with unexplained infertility, you don't necessarily have to go straight to IVF. You can start out with IUI or timed intercourse. But the reality is that IUI and timed intercourse, well, timed intercourse itself with unexplained infertility means that everything is working fine, right? And so it's not, the problem is not that you're not ovulating, or the problem is not that there might be mild issues in the sperm. And those are the people who benefit more from IUI or timed intercourse. The people who benefit more from timed intercourse are people who just need some help ovulating, which is not your case in unexplained infertility, right? Or the people who might benefit from an IUI are patients in whom there might be mild issues with the sperm, and you're hoping to circumvent those issues by putting the sperm inside the uterus. But in your case, where everything is normal, it means that the IUI or the timed intercourse is not addressing what is causing your infertility. And that is a bit frustrating, I'm sure, for you to hear, because we don't actually know what is causing your infertility. But the answer is that it's most likely not that you're not ovulating properly, and it's not that there are issues with the sperm. And that is why IVF in those cases may be a more beneficial method. So people with unexplained infertility absolutely do get pregnant with IUI or timed intercourse, but the reality is that those forms of treatment are not necessarily addressing what may be causing your infertility. And so in those where those treatment options fail, IVF is going to be the only other option that we have.
Perfect. I think that is very helpful. Thank you, Dr. Toomey. And I know we are at the end of time, so I also just want to thank all of our attendees who have joined tonight. Thank you for your questions, for learning a little bit more about the journey. I also just want to share here for folks that are ready to potentially schedule their new patient appointment with a Prelude Network clinic. You can find Dr. Toomey at Advanced Fertility Center of Chicago. We have this QR code that can be scanned. And for everybody in attendance, and even those who are not able to attend but still registered for the webinar, we will be sending out an email as well with the recording of this webinar so that you can have it, go back and reference it. And thank you again so much to everyone for joining. We hope everyone has a great night, and thank you as well, Dr. Toomey.
Thank you very much, Elena. Thank you to everyone. Thank you.
Good night.
All right. Good night.